I want to put it out there that I'm no expert in point-of-care ultrasound. I have a developing interest in it, and I know that many of you who are adult trainees or consultants in emergency medicine probably use this more frequently in your day-to-day practice than I do. We are introducing it to our emergency department at the minute with an interest in just our nerve blocks, IV access, but also from the point of view of cardiac assessment in our undifferentiated shock patients. So that's what we're going to talk to you about today. I think with the talks about using fluid in these children and the increased risk of overloading them, using all the tools that we have available to us is very important. And this is one of the tools that we're seeing more and more used in pediatrics. It's a big interest at the minute. There is limited evidence, and I'll go through that a bit, but I think it is a potential tool that we can consider using to help make those decisions when we're not quite sure whether more fluid or more inotrope is necessary, or where we're going from a point of view of cardiac arrest and finding out potential reversible causes. So we'll plow on through this. That's my proviso over, and hopefully you've been dazzled by all the science so far, or the pharmacology, and this is a bit more airy-fairy, get to show you some videos and have a bit of fun with it, all right? So let's try that. So there's the disclaimer. So what is POCUS? And I think it's important to know this. So we're not doing POCUS because we want to pop a probe on someone's chest and find out what are all the potential cardiac abnormalities this child may have. All right, that's for formal echo. Point-of-care ultrasound is asking a specific question. So when you're approaching a child and thinking, I'm going to put this ultrasound probe on them, you have a specific question. Is there a tamponade present here that is causing this hypotension? All right? And you're asking a specific question, looking for a specific answer. You're not going hunting. All right? It's a tool to help you in your decision-making, and it's a rule in, not a rule out. So you can't, at the end of your ultrasound scanning, without sufficient training in radiology, say there's nothing going on here that I'm concerned about. But what you can do is you can look at it and go, oh yes, there's a pericardial effusion, or yes, there's a tamponade, that then you can act on and treat. If there's still concerns at the end of it, you need to get a formal echo. Or if there is concerns that there still might be something going on with the heart, you need a formal study. You cannot assume that your scan is definitive. Okay. One of the nice things about point-of-care ultrasound is it's not static. You don't get your CT scan and then that's it. You have to sit there and wait. If you've given fluids, you've assessed that the child is fluid deplete, and you want to give fluids. After you've given a fluid bolus, you can go back, have another look. Has that made an improvement to your IVC, your right ventricular function? And if so, or if not, then you can consider further fluid boluses or increasing your inotropes. Okay, so it's not a static. You can recurrently use it. So that's what is and isn't point-of-care ultrasound. So from an echo point of view, what are the questions that we can ask when we see a patient so firstly, in cardiac arrest, what's going on with the heart? Is it on standstill? Is there PEA, pseudo-PEA, or VF? Basic question from that point of view. Is there a pericardial effusion? And more importantly, and from the point of view of this course, what I'm going to be pointing out is more the extremes of these situations rather than the minutiae in between, which require you to do calculations of ejection fractions, etc. So this is more, is there a gross abnormality present that needs to be addressed? So from a pericardial effusion, it's not the pericardial effusion you're actually asking, it's whether there's tamponade, whether there's hemodynamic compromise relating to fluid collection around the heart. Okay. What is the global function of the heart? Are the ventricles contracting properly? Are the ventricles of the right size? So left ventricle meant to be larger than the right ventricle. Is that the status quo in this child? Is there good contractility, or is there a dilated, poorly functioning heart? And then is there normal preload? So what does the IVC show? Is it collapsing? Is this child fluid deplete? Is there a hyperdynamic right ventricle? Or is there a plethoric, overfilled IVC with a distended right ventricle, which may indicate that this child's either overloaded or there's an obstructive picture or possibly a pulmonary embolism. present. So it can help you with your differential diagnosis. So the evidence in adults, there's actually quite a lot. This is a very brief summary from an article from an international consensus of focused cardiac ultrasound for a number of different uses, and I've just drawn out the ones that we're going to talk about today. So it's sensitive for cardiac injury and trauma. Okay, and its use has been shown to allow more rapid diagnosis of reversible causes and better survival in trauma patients and adults. ED consultants or physicians are accurate at diagnosing pericardial effusions, almost to the point where diagnosing physiological fluid around the heart is possible, and that's something that you need to take into consideration when we talk later on. They can accurately characterize left ventricular function in hypertensive patients. And ED versus cardiologists identify low ejection fraction visually with 98.7% sensitivity and 87.9% specificity. ED is comparable to formal echo in obtaining those hemodynamic data, such as the ejection fractions. And focus can be helpful in cardiac arrest. So it's a bit of an iffy statement there. It can be deployed rapidly, which is one of the benefits of it. It's at the bedside. You can have it quickly, as was mentioned by Chris earlier on when talking about pneumothorax. It's something that you can quickly put on a chest and get a diagnosis or a indication as to what may be going on. And it can be repeated. Assessment of IVC in the thorax can help with assessment of fluid status and responsiveness in patients with shock, and that is a bit of what we're going to be talking about today. So in pediatrics, the evidence is a bit more scarce. There's a lot of groups now starting to look at developing training programs, curriculum for the introduction of pediatric point-of-care ultrasound. But on a survey, I think this American study, 61% of pediatric emergency departments were using point of care, with 59% of those specific for cardiac applications, and effusions being the highest proportion of that, and then 7% for more advanced. There's a whole wide range of things that you can use it for, and we're going to keep it simple for this. Pediatric emergency physicians and critical care physicians, 91% accurate at diagnosing pericardial effusions, cardiac contractility, abnormalities, and LV enlargement. So it's pretty good, but again, limited training needed. Pediatric emergency medicine physicians are accurate and reliable compared to cardiologists in assessing LV function and probably preload by assessing the IVC. There's very limited evidence in cardiac arrest, although there are now considering it for traumatic cardiac arrest and their use in algorithms for pediatric traumatic cardiac arrest, but as yet hasn't sort of reached to formal protocols. IVC collapsibility and IVC aortic ratios may correlate to fluid status in children, but again, limited evidence for that. One study suggested the IVC aortic ratio being the better judge of fluid status in children. One of the big teachers of point-of-care ultrasound is Sick Kids in Toronto, and one of their lecturers would say visualization of it is just as effective at this point in time without the calculations. But and what we're talking about here again is the extremes. I'll be showing some pictures of just what the extremes look like and how it differs from adults and how an extreme collapsible IVC can be reproduced just by doing the study incorrectly in children. So transducers, so most people will use POCUS, fast scanning in their adult emergency rooms. And they use the curvilinear probe. Curvilinear probe can be used for the entire FAST and EFAST scan, but you'll probably find in the young children your probe is much too large to get into the spaces that you require, and therefore using the smaller probes, the high frequency probes and cardiac probes can be more advanced, more beneficial in getting the views you need. You can use the small curvilinear probes. You can use the phased array probes or microconvex. As long as they're the high frequency, you get pretty good images. Now, there's a bit of controversy. I know a lot of you work in pediatric district general hospitals where you probably do telelink echoes with cardiologists in Belfast. And so therefore you have training in which the way they like to use the probe, which direction you point the pointer, how you flip the image, etc. The point I'm going to make here is as long as you know which orientation you're looking at and you know how you're using the probe, it doesn't matter whether you use it from the point of care ultrasound method or the cardiologist method, as long as you know which way you're looking at it. Okay. So the view we wanted to highlight in this course is the subcostal view. My limited training is the RChem level 1 training, which I did in Birmingham, and I did it in adults and fighting with very obese people, trying to get a view through the liver, pushing down really hard on their abdomen, trying to get in there to get a good view. It doesn't necessarily happen like that in children. They're smaller, there's less fat, and the views when I'm practicing up in ICU is very easy to get brilliant pictures in children. Subcostal view, you can pop it on, start at the belly button, flattening it down to the skin and pushing up towards the left shoulder with the probe pointing up to your right shoulder, and you'll very easily get a good view using the liver as an acoustic window. Okay, and what you're seeing here was there a pointer? No. What you're seeing here, where is it? There it is. All right, so right ventricle is the closest thing to your view, followed by your right atrium beside it. Then further away from the liver being the top at the pointy bit, is your left ventricle and then your left atrium. And in this view, you see the 4 chambers, but you also see your mitral valve and your tricuspid valve. And this is a good view for looking at pericardial effusion. You can see function of contractility, but it's not so great at assessing your chamber sizes and parasternal long axes, for example, which I'll show you in a second, is much better for function, and then your apical 4 chamber for heart sizes. But from a point of view of an easy view to get and a rapid assessment in an unstable child, this is the easiest view you're going to get. It doesn't interfere with CPR or any other resuscitative measures going on. And it allows a view of the 4 chambers. Okay, for getting an IVC view of the aorta and IVC in transection, you just lift the probe up to 90 degrees and move it down, and you'll see those come into perspective. And normally if you're going to do a measurement, a ratio of those two should be a 1-to-1 ratio for normal, and you do that at the level of the left renal artery, but we're not going to get into that today. The other part of the subcostal view is to rotate at 90 degrees, so the pointer is pointing up to the neck, and that gives you your longitudinal view of the IVC, in which you should see the right atrium pumping in the corner, and then the IVC coming down with the hepatic vein joining it. And what you're looking for in this is the variability in respiration to see how much during respiration the IVC collapses. It should be less than 50%. And if it's more than 50%, you're thinking there's fluid depletion or you're underhydrated. Okay. Other view, parasternal long axis. This is where you'd put your lead 2 of your ECG on your chest. Okay. Pointing down to your left hip. And this gives you a view showing your right ventricular outflow tract, your left ventricular outflow tract, your AV valve, mitral valve, and your left ventricle. Okay, and this is good for looking at function of the heart, but not so good at looking for pleural effusions and tamponade. The reason I mention the 2 is because obviously if you see any abnormality, it's always better to have at least 2 views of that abnormality to ensure that you're getting the right diagnosis. And that is in the evidence as well, is that you should have more than one view. However, they do recognize in an unstable child in an emergency situation, one view may be all that is necessary. Okay. There's the apical four-chamber and parasternal short axes as well, which you can get, and we're not going to talk much about them. So in arrest, the things that you can find out in arrest is whether there's cardiac standstill, whether there's PEA, so some sort of contraction of the heart, organized contraction, whether there's output or not, or whether there's pseudo-PEA, in which there's organized formal contraction with good contraction of the heart, and maybe you're just not able to feel the pulses. Now, feeling the pulses in children is notoriously difficult, and there's about 73% success rate in actually getting a pulse in a child when there should be a pulse present. Okay, so it can give you a bit more information. VF should not be an indication for doing a point of care ultrasound. Okay, VF is diagnosed on your ECG or your pads on, and you should do nothing to delay formal resuscitation of that child. Okay, so VF is not an indication to do POCUS. If you have asystole or PEA, then during your 10-second break in your CPR, it's been shown quite effective to pop the probe on and have a look at what is going on with the heart. In children, the evidence is very little, and I don't think I'm going to change my practice based on what I see on putting a probe on at this point in time. In the traumatic cardiac arrest, if you see standstill on ultrasound, then it should trigger your traumatic cardiac arrest protocol. And if after resuscitative measures there's still standstill, that is poor prognosis, and you probably is one of the indicators that they say that there's futility on proceeding. And that's traumatic cardiac arrest. From a point of view of adults, the adult literature says that if you see standstill, there's a poor prognosis. It's unlikely to get the person back. But at the minute, I'm not convinced that the evidence is there to adjust my practice based on the echo findings. Now, what it does help with, and what we're going on to talk about, is looking at reversible causes for cardiac arrest. Okay, so not just the standstill, not just the VF, but whether there is a reversible cause. Sorry. So on the right, asystole, there's no contraction of the heart, and what you see is the swirling is just the blood in the chambers, okay? And on the left, you can just see some fasciculation of the muscle, showing the ventricular fibrillation, okay? Am I doing right? So indication tamponade. Now, initially I said pleural effusion, but as I said, pleural effusion is not our question here. We're talking about extremes. We're looking at hemodynamic compromise. What is causing our undifferentiated shock at the minute? Okay, so pleural effusion on ultrasound, you can pick up physiological pleural effusion. So we need to determine how much fluid is there, and is this causing compression to the heart and preventing it from beating properly? And then that is something that needs to be dealt with. So tamponade is our question, and I know many of you will think Beck's triad, let's think you can get muffled heart sounds, raised JVP, hypotension. You can look at the pulse wave and look for pulsus paradoxus. You can get an ECG that shows you electrical alternans. And these are all clinical findings that you might find in a person with tamponade. However, in children, the findings aren't always as easy as that. Small necks, huge heads, JVPs can be difficult to assess. And only in about a third of adult patients will you actually get the classical findings of tamponade for the diagnosis. So this is a ECG of pericardial effusion. So you can see there's a fluid. This is a subcostal view. There's fluid around the heart, also so encircling the heart. And what you're looking for is whether there's compromise to the right ventricle. So what you get is right ventricular diastolic collapse. And what you're looking for here is the ventricle collapsing down, and then the right atrium often looks like a person is jumping on a trampoline. You'll see tenting in of the right ventricle as the valves close. Okay, so you're looking for whether the fluid around the heart is causing hemodynamic compromise, and if so, then you want to act on that. The other thing that ultrasound does is it allows you to perform a procedure a lot more safely than if you were doing it blindly through anatomical markers. Typically going through from the xiphoid up into the heart, you can potentially cause liver damage, and there's a higher risk of complications, whereas ultrasound's going from a different perspective. You may be able to get to it quicker, aspirate out, and you can see where you are easier, so a higher success rate of pericardial centesis. So this is a traumatic tamponade with a large clot. Obviously, you can see here that there is almost complete right ventricle collapse, and the right atrium looks like a loose bag just sort of flapping in the wind. So this person is going to need urgent clearance of that clot in order to get to restore circulation. The other thing you can look at in it is the IVC. If you've got obstruction to right ventricular function, you get backflow of fluid, and you can get a distended IVC, and that's what a plethoric IVC looks like. So your signs of tamponade are your valve closed and right atrium collapse, plethoric IVC with less than 50% variability on respiration, valves open with right ventricular collapse, mitral valve inflow variation of greater than 25%. As I said, if you're looking at minutiae, you should go in and measure that. Again, this is looking at one view and looking to see if there's something causing restriction to the heart. Pitfalls, if you look at it from the parasternal long axis, which we weren't really going to cover today, you can see some epicardial fat that can mimic pleural effusion, and in children that's less likely to be seen. And again, from this point of view of this course, you're mainly looking for something that's causing hemodynamic compromise, and a bit of epicardial fat's not going to do that. Size of effusion doesn't equate to hemodynamic compromise. So in adult studies, they've seen that around 150 mils can cause tamponade, whereas if it's accumulated quickly, whereas if it accumulates over a long period of time, the heart compensates a bit better, and you may not have tamponade even with a large effusion. Sometimes it's difficult to know whether it's pleural or pericardial fluid, and again, I say in the extreme, you'll see signs of tamponade if there is a pericardial effusion. If it's a pleural effusion, it doesn't generally encase the entire heart, and you can, if you know what you're doing, you can look at the lung apices for fluid, and the other thing is to look at it from a different view. And if you have a look at it from the parasternal lung axis, a pericardial effusion goes between the aorta and the heart, whereas a pleural effusion encompasses the aorta. Okay. So this is all about undifferentiated hypertension. Looking at heart function, there are measurements that need to be done, but there's also shows that just having a global look at what the heart is doing can be helpful as well. So looking at whether there's dysfunction of the ventricles can help you know whether if you're going to continue on with pushing fluids in this child, or whether they've actually got a poor functioning heart that's already overfilled, and maybe inotropic support and urgent cardiology opinion is necessary. So you're looking for wall motion. This is a normal heart. And you can see that the left ventricle, so this is looking at your subcostal view, liver at the top, right atrium, left ventricle. Oh, thank you. It's only like near the end of my talk. So left ventricle, right atrium, and then, sorry, left ventricle, right ventricle. So you should have a smaller right ventricle than a left ventricle, and you got, what you're looking at is septal wall motion and contractility, as well as mitral valve movement. So you got good mitral valve movement, you got good pumping of the heart. That's not your cause of hypotension. However, in this one, this is a parasternal long axis, sorry, because that's your left ventricular outflow tract, left ventricle, mitral valve, and right ventricular outflow tract with the liver at the top. Okay, so you've got poor contractility of the heart with poor mitral valve movement, and this is severe left ventricular dysfunction. So again, it's just a global look. If you've seen a normal heart pumping away, and you have a look at a distended left ventricle that isn't moving very well with poor mitral valve, that is a concern. Fluid overload in this child probably going to worsen their circumstances. This is talking more about the sizes of the chambers. As I said, apical 4 chamber is a better way of looking at comparing the sizes of the different chambers. This is subcostal view. It's a poor window. It's my picture. So we're not saying anything more about it. Obviously, I haven't got the depth right. The gain's a bit off. We're not going to talk about it. All right. So what we have is the right ventricle, left ventricle, and what we can see here is the right ventricle is much larger than the left ventricle, as well as the septal wall bending into the left ventricle, which shouldn't normally happen. You normally have a higher pressure on the left ventricle, so the ball slightly bends into the right ventricle. So this child has a dilated right ventricle. And if we had that plethoric IVC that I showed you earlier on is a picture from this child. Okay, so it has a distended IVC as well. Okay. This is parasternal long axis looking at distended right ventricle as well, pushing into the, so distended right ventricle, that's meant to be the right ventricle outflow tract, whereas that's normal, okay? So it's distending, it's pushing in, it's much larger than it should be. And that's the picture that you'd probably see in a person, an older person, if you're concerned about dyspnea. They've come in with dyspnea, you pop a probe on, you see a distended IVC, you see an enlarged right ventricle. One of the concerns you're going to have is a pulmonary embolism, and that's one of your 4 H's and T's, okay? So if you've got a person who's, you're considering 4 H's and 4 T's, and they've got distended right heart with large IVC, this could be a PE as well, okay? Preload, just briefly, we're looking at fluid status. This is one of the children in ICU when I was practicing again. Shit picture. So you got the right ventricle, right atrium at the top here. You got your IVC with your hepatic vein coming down here. And that's the view you want. And what you're looking at is for respiratory variation here. And what is good about this picture is that it indicates what you don't want to use this for. Right? If you've got a ventilated patient, this is useless, okay? Because you've got increased thoracic pressure, and you're not going to see the respiratory variation. All your IVCs are going to look big. So when you're looking for these in these children, it's the unventilated patient you want to have a look at for your IVC, okay? Once they're ventilated, it's going to give you limited information, okay? So IVC is up. What it does also show you is some of the limitations or some of the difficulties in children. In adults, you need quite a lot of depth to have a look at your IVC. Here, standard depth setting for IVC, and I'm picking up the spine of the child, okay? This is the aorta, IVC, and liver at the top. So I've got the whole depth of that child in one view, okay? So just be aware of that. And one of the things that comes along with that, that's the plethoric one again. One of the things that comes along with that, you could be tempted to think that this is a collapsing IVC, underfilled child. But all that is me not realizing how much pressure you should add to look at this IVC. So having practiced in adults, I come here and I pop the probe on and I'm searching around. I can't find it, and eventually I find it, and the reason is I'm pushing too hard and I'm collapsing the IVC down. Okay, so in children, just be very careful of the pressure that you're putting on, and make sure that what you're interpreting is not just you intermittently putting pressure on the child. The other limitation that I've found is that this was the first image I got, and I thought, yippee, first shot, IVC. Okay, that's the aorta. It's thick-walled, okay? It's not collapsing at all, okay? You got the right ventricle there. I don't see a hepatic vein entering into my IVC at all, okay? So I've just got it at the wrong angle, at the wrong place, and what I'm picking up is the aorta. And that's 3 of the pitfalls of doing IVC assessment in children. So make sure your pressure's okay, that you find your hepatic vein coming into your IVC, and then look at it from a point of view of collapsibility of the IVC. Now, just eyeballing it, if you've got a good collapsing IVC, you should be able to see that. If you've got a distended IVC, you should be able to see that as well on a child, just as well as you do it in an adult. So what does it mean? Hypertensive and tachycardic patient. You've got a collapsing IVC, hyperdynamic heart, so the heart's beating really fast or it seems a bit loose. Consider fluid challenge and then rescan. Beauty about ultrasound is rescanning can give you more information. If your IVC is normal, or you think it's got good variation, less than 50% variation with respiration, and cardiac function seems okay, then consider identropes if you're hypotensive. You don't want to be, as we've talked about, you don't want to be continually pushing fluids into these children with the risk of causing more damage. So it's one of those situations, if they're not dehydrated, if they're not fluid deplete and they're hypertensive, you need to consider bringing their blood pressure up another way. If the IVC has no respiratory variation, or RV is dilated, or you've got an enlarged heart, you need to think of other causes of that, and maybe, or if those are absent, maybe you need to think of inotropic support and cardiac input rather than flooding them with more fluid, causing the situation to become worse. I will get to that. Learning, RChem do a good course, level 1, level 2 ultrasound. What's good about their course is once you've done it, you have to then do a number of scans to show that you're gaining the competencies. A lot of the other courses don't give you that exposure. So if you're wanting to do that, I would suggest talking with your local ED or the consultants there and seeing if there are trainers around there who are willing to help you sign off on those. It can be quite difficult to get the numbers that you need, and it's very adult focused. They look at AAAs, cardiac, and fast scanning as the main things, and IV access. The field course is a resus run course looking at use in cardiac arrest. Cactus course is a pediatric driven course. I think it's a 2-day course. It doesn't give you any accreditation, doesn't give you practice, but does talk to you about the applications of point of care ultrasound and some of the limitations in children. And they're the ones looking at, I think at the minute, looking at a curriculum for pediatrics. Online, there's a number of different courses that you can do to get the images you need and the techniques that you need. So guys, any questions? Keep them simple. I'm simple.